Hi there, welcome. My name is Kelly Phalen, and I'm a nurse practitioner with the IBD program in Halifax. And welcome this evening to hear our guest speaker. Our topic tonight is near and dear to the hearts of nurses in general and to IBD nurses in particular, and that is collaborative care for IBD, a team approach. We're very fortunate to have with us Dr. Vivian Huang, who is certainly well known within the IBD community. She is Assistant Professor of Clinical Investigation, as well as the Director of the Preconception and Pregnancy and IBD Clinical Research Program at Mount Sinai Hospital in Toronto. And like many of you, I've really been looking forward to what she has to say. So I'll let you go ahead, Dr. Huang.
Right, thank you, Kelly, for the invitation. As mentioned, I'll be talking about collaborative care for IBD, a team approach. And these are my disclosures. There's nothing directly of conflict of interest for the presentation and discussion. The three objectives I hope to cover in the next about half an hour or so are to discuss the collaborative care models. And I believe there might be an option for you to type in the chat box, but I'd be curious to hear people's different models and approaches in your own institutes and clinics. And then just a brief discussion of some algorithms and self-management plans that I've used in my clinics, but I'm curious as well to hear what other people are using. And then I will have time for open discussion and sharing of each other's collaborative care models in your institutes. So when you actually think about collaborative care, it could mean many different things depending who you ask. I think most of us think of the multidisciplinary approach, working together with multiple disciplines along with the patient. Actually, Health Canada has an actual definition if you go to the primary health website of Health Canada, and it's that collaborative care is a patient or client-centered process in which two or more professions or disciplines interact to share knowledge, expertise, and decision-making in the interest of improving the patient or client's care. And similarly, I did my IBD fellowship and worked in Alberta. So Alberta Health Services has a really nice, very similar definition. So multi-professional, patient-centered approach to care, team-driven, population-focused, measurement-guided, and evidence-based. So that highly applies to IBD, which, as you know, is a very chronic disease, has ups and downs, remission and activity, and a significant impact on our patients' lives, the quality of life, their function, and participating in going to school, taking care of the families, going to work. And there's a lot of measurements that we use, and we'll talk about some of those tests, and a lot of studies looking for evidence of why we're doing certain things. However, it also, IBD is not just the gut. There's a lot of extraintestinal factors and societal factors. And Kelly and I, just before the presentation, were chatting about some of those, like, for example, anxiety and depression play a huge role. It's very, very prominent in people with chronic illness, and it can affect their care, affect their adherence to medication, for example, or willingness to do tests. And so all of those we cannot manage individually and needs to be multidisciplinary and team approach. And one of the things that I liked was recently published is the 5C concept. And I'm not sure if you may have heard of this, but it was a consensus group, international, and went over a few meetings and Delphi type of approach to come up with proposed best practice. And they proposed this 5C concept, and the 5 Cs are listed here. So comprehensive IBD care, so monitoring the disease clinically and evaluating and managing complications, and having specialist centers. So in this case, like IBD centers that deliver some specialist training for clinicians and allied health. And then collaboration, greater use of those multidisciplinary team meetings and networking, collaboration with other specialists such as rheumatologists or dermatologists. And then communication, so developing better ways to communicate to our patient to help them understand their disease and the risk factors and their phenotypes, develop better educational tools and shared goals between the physician, I would say clinician or healthcare team, and the patient. And of course, clinical nurse specialists play a huge pivotal role in supporting those patients and helping the physicians to spend that appropriate time with the patient. And also, many patients may not disclose things directly to their physicians, and often it's a disclosure and with their nurses and nurse specialists. And then the care pathways is the final C to develop patient-centered pathways and action plans, rapid access and seamless transition. Ultimately, I would say that all of this is meant to have shared decision-making with the patients. So again, the patient is always in the center, and it's always to help them with their care. So they need to understand what's going on with their disease and why all these different team members, what roles people play, and why we're ordering tests or certain management. So once again, this is just a pictogram that I didn't actually develop, but it's a nice concept of that circular aspect of collaboration. And the patient is always in the middle. And then all their physician team members, nurses, nurse specialists, and nurse practitioners, dietitians, pharmacists. I would also add infusion clinics because they're giving the biologic infusions, friends and family and society. And I should put those other specialists like psychologists, social workers, and the other allied health specialists. So once again, the other specialist that comes to my mind when I think about collaboration and care is usually the rheumatologist or dermatologist, because many of our IBD patients do have these extraintestinal manifestations. And not only in terms of managing their symptoms, but it actually makes a difference in potentially in which treatments we recommend. As you know, now there's a multitude of biologics therapies of many different classes, and then there's the small molecules of the JAK inhibitors and now the S1P modulators. So for example, in rheumatology, if a patient has axial or ankylosing spondylitis, we need that diagnosis. In some cases, you may be able to diagnose that from CT scan or imaging. Other cases, it could be less obvious and may need the rheumatologist to officially give us that direction. And then we would direct more towards like a JAK inhibitor or anti-TNF, first an anti-TNF as a preferred treatment. However, if they have IBD-related concordant arthritis, perhaps then it could be gut-specific, and vedolizumab, for example, may still help. In terms of dermatological manifestations, of course, there's erythema nodosum or pyoderma gangrenosum, and that may help guide which therapy to recommend. Some cases can be, as you know, could be quite severe and refractory to treatment, and we need our dermatology colleagues to be involved in their care. And again, psoriasis is also one of the more predominant comorbidities as well, and can guide which therapy. So I find that many patients who have these, it's not enough just for ourselves from the gastroenterology side to treat these. They often will need that collaboration with their other specialists. And of course, near and dear to my heart is the preconception and pregnant population. And now again, like with all this explosion of new medications coming out, we always have to think about that at all time points. Every encounter that you're seeing these patients, whether they didn't disclose that they're trying to get pregnant or in their family planning, we need to keep that in mind. Keep in mind those other extraintestinal manifestations, where they are in the life stages, and recommend the appropriate therapy. So once again, multidisciplinary care, very important. And that's, to my mind, what comes when I think of collaboration and collaborative care. And this is actually a publication from yourself, actually, in London Health Sciences. And I think Heather was a co-author on this one. And they presented on their multidisciplinary team meetings. So in their institutes, they have weekly meetings with gastroenterologists, surgeons, radiologists, pathologists, IBD nurses, and fellows. And they reported on 63 of their weekly meetings, 181 patients, 136 had IBD. Some of them were new diagnoses, some of them were flaring presentation, and then some of them were more like chronic patients, and they had a discussion for management. So what they showed is it actually does change clinical management. 26% of their patients, it actually changed their final management plan. And then they list all their other outcomes of what came about this multidisciplinary meeting, like a referral to surgery, to move ahead with surgical planning. Some patients actually did go on and have that surgery, start or change a biologic therapy, adding steroids, nutritional therapy, and other medications. So here at Mount Sinai, they didn't really have the same kind of meeting before, but for about the last 3 years, I've taken over the rounds, and We have a surgeon, Dr. Montaj Brar, who drives the multidisciplinary care meetings in these weekly rounds. Unfortunately, we have a lack of access to enough radiologists or pathologists that are willing to meet weekly. So our rounds that would be similar to these occur every 3 weeks. And then we also do quarterly rounds with the pediatric IBD specialists to talk about some transition cases, and then try to do quarterly rounds with the hepatologists to discuss about our primary sclerosing cholangitis in IBD patients. Where I trained before, I'm not sure if anyone from Edmonton is on the call, but we actually did have weekly meetings with the gastroenterologists, IBD nurses, and the fellows. And then eventually I recall having every couple of weeks, we'd have the surgeons coming as well. So I found that's really helpful, and you hear from each other the different approaches and similar approaches, and then can change management for patients who need that. So again, I'd be curious to hear from those of you in the audience, how frequent, if you have multidisciplinary team meetings, how frequent are they at your institute? What are the barriers that you've encountered in trying to get all these different specialists and team members to commit to these weekly or biweekly or monthly meetings? And then the other approach to collaborative care is actually like intervening in a collaborative way. So many of us are probably at lack of access to psychologists or psychiatrists. And this article here, this center, they developed a collaborative care model, which is illustrated in the middle. And they had a care manager and psychiatric consultant, and then the IBD nurse and the gastroenterologist. And they survey patients with the patient-reported outcomes of PHQ-9 for anxiety and depression and the GAD-7 score. And then people who are flagged with psychological distress would be invited to go into this collaborative care management. And then basically it's like the intensive monitoring and having ongoing assessment of their anxiety and depression scores, and then appropriate treatment or therapy with guidance from the psychiatrist. And they showed that of the 39, it's a small study, but they showed that 39 patients enrolled, 19 people actually then participated in this collaborative care model. And 47.4% did have a response or remission in their depression, and 36.8% had a response or remission in anxiety. And as you know, anxiety and depression can adversely affect the patient's care for various reasons in terms of adherence to tests and medications. It could also affect their symptoms and reporting of their IBD actual clinical scores. So something like this might be useful. And again, before this seminar, Kelly and I were just chatting about this, and I'd be interested to hear from Kelly again, but it sounds like they've kind of accessed their psychiatrists to be able to guide them to how to initiate some antidepressants or anti-anxiety medications, because many patients do not have access to psychiatry or family medicine specialists who could do that for them. So it comes back to the GI group to try to help these patients. So once again, later on, it'd be interesting to hear from everybody how their clinics and clinical practice are trying to help the patients from the mental health aspect. And then I wanted to show about this. So in terms of trying to improve quality of care with this collaborative care approach, it actually can benefit the population or system, health system. And that's part of collaborative care too, is to help the patient, but also try to help the healthcare system so that you can help more patients. So in the States, there's a large collaborative called the IBD Chorus. BTS stands for Breakthrough Series Collaborative. And it's a national multi-center improvement collaborative, and it consists of many academic, community, and private practice IBD care centers across the USA. And they use what's called a feed-forward and feedback patient-reported outcomes. So, they survey these patients who are enrolled in those different centers on those various quality of life and mental health and other PROs. And then they have that registry to see the outcomes, and then they can have a cycle to try to improve the quality of care in those institutes. And I just list here and those various attempts or clinical care changes that they tried to implement. And so, for example, these sites have implemented what's called a high-risk patient list, weekly team huddles, so like the MDT meetings, proactive nurse phone calls to those high-risk patients, patient education materials. They've tried to reserve urgent slots in their clinics. High-risk patients had to follow up within 90 days. They would phone call to patients after an ED visit if they got discharged home. Rapid access clinic, urgent care hotline, try to return clinical calls within 4 hours if they could. Standing nurse orders for urgent care calls so that if a nurse is answering or addressing the patient, they have the initiative to order certain tests and management. And then a monthly attendance at the collaborative webinar meetings. And what they showed is that this can reduce healthcare costs and improve the quality of care. So the way you read this graph, on the blue, the left is the difference in the average yearly cost per patient between intervention and baseline. So below the $0 is savings. So all these sites from 1 to 16, you can see like the orange is at the top, whereas the blue is at the bottom. So that's good. So these 16 sites, they saved costs through all those different methods of trying to improve quality of care. And the other 5 sites ended up costing them more money when they tried to implement those quality of care initiatives. The orange line is a statistical thing where they run these scenarios like 1,000 times and then to see like, are they going to save costs by doing those quality of care initiatives. So orange line at the top where the blue and the orange cross is good, and then orange line going bottom is not so good. So then they tried to look at why those 16 sites on the left are saving costs, whereas the other ones on the right were increased costs. And it didn't really seem to be anything in terms of academic or community or private practice. So they didn't think that that was playing a role. They looked at whether those initiatives that they were doing, and they all seem to be doing the same recommendations from this IBD quorum. And so they figured it may just be the way the healthcare systems are different. So that's in the state. So every like institute and every state would have a different cost or coverage. So when I think about this for Canada, you know, there's different provinces and territories, and then within each of our provinces and territories, each institute has a different funding model. And so that might be a barrier for some institutes to try to implement certain quality of care initiatives. So I always think that you have to be problem solving and you know, come up with solutions. Is there ways to automate some things with electronic health or like apps that patients could monitor, algorithms, action plans that patients can do to try to offload some of those costs, but yet improve the quality of care. And again, then that brings us to what are those quality of care initiatives. So I listed out for you like all those different initiatives that they did, but ultimately it breaks down to like 4 dimensions. So clinical status, so that's monitoring the disease, recommending treatments, you know, the clinical scores, but then functional status for the patient, patient experience, and then ultimately trying to reduce costs by reducing emergency room visits or hospital stays. So in Canada, we have something similar. It's the IBD Global Rating initiated by the CAG and CCC. And the 2 dimensions that are kind of suggested for the Canadian system is clinical quality and quality of patient experience. So clinical quality, and a lot of the initiatives that they are recommending is patient information and education sheets, always making sure patient safety and well-being, quality of disease management, appropriateness of treatment, investigation, and then communicating back to the patient those management plans and results. And then the patient experience that was felt to be important was access to their clinical team, booking and easy access to clinic visits, timeliness of care, and ability to provide feedback. So slightly different in the States, but I think along the same lines of trying to improve quality of care, but also patient experience, and then at the same time trying to reduce healthcare burden and costs. So one of the things, some publications have actually tried to quantify some of these initiatives. And then St. Mark's, they published on their experience of using a nurse-led phone clinic. And in this one, it was more lower risk IBD patients. And they define those like non-complex. And that definition would vary, I guess, depending on comfort level and experience of nurses and the clinicians. And what they would offer these patients was a nurse specialist-led telephone clinics and a rapid access clinic. And they showed over time, this is from 2017 to 2018, over time, the percentage of patients that were needing to attend like a clinic appointment with a physician went down. So that's the blue line. It started at about 50% in the beginning, and then by the end, it was down to about 30%. And so that's one way that you can try to reduce the clinic burden of having to bring these people back to clinic, is that they could be managed like remotely, virtually by phone or by e-health monitoring, and then brought in for clinic when needed. So again, we're talking about multidisciplinary with the patient in the middle. So then that leads me to the next section where I'll talk a little bit about P4 medicine. So some of you may have heard me talk a little bit about this before, but all of this collaboration will not work unless the patient is collaborating in their care. And for the patient to collaborate, they need to understand some of the concepts of prediction, prevention, personalization, and participation in their care. So prediction is to get them engaged in understanding why we order tests like fecal cal protecting. You know, it predicts active disease or predicts that they may flare unless we do something. And objective tests, you know, if we have a CT scan that shows their stricturing is worsening, you know, that's going to predict that they might run into trouble with obstruction, doing endoscopies. I think if the patient is educated and understands that better, they're more likely to participate and do those tests. And I think there's some evidence about that. There's this study from Canada that showed that in fact, you know, out of the 67% of what they did was they surveyed 210 patients across 10 different provinces and territories. And 36.5% of these patients said they refused the blood test that was ordered. 67% of respondents had a stool test ordered, and only 3% said they refused the stool test. So patients will do the stool test if they understand what it's for. And the patients who said they were comfortable, they had a comfortable doing these stool tests, they also reported, you know, they had low to moderate concern for the results, and they understood the value of doing these stool tests, and that seemed to increase their comfort level to do stool tests. So I think one of the common misperceptions is that patients don't like doing stool tests, but I think part of that is actually like if they understand why we're asking them to do stool tests, they'd be more likely to participate in that testing. And then, of course, if you can predict, then you can hopefully prevent. So I've used the fecal cal by counseling people, like, you know, fecal cal predicts that you have inflammation, and you're going to have like an 80 to 90% chance that you might flare. So I asked them, like, are you taking your medication? You know, and some patients I find still won't listen. You know, they're going to flare, and then they understand, oh, you know, the doctor was right, and like that test predicted they're going to flare. And then when I check up with them again, they actually say that. They say, oh, yes, you know, I stopped my med and I realized that now I'm not going to stop my medications anymore. If a patient has strictures, you know, you can explain it to them and try to prevent those obstructions by counseling on their diet, a low fiber diet. If they have comorbidities like irritable bowel syndrome, I find that educating them so they understand the difference between irritable bowel syndrome versus like active IBD, that they might follow the IBS management for those symptoms and prevent those symptoms from contributing to their poor quality of life. And then again, for psychiatric, to make sure that we can survey our patients and flag that routinely so we can get them the care they need. And then, of course, if you can prevent complications, then it would prevent those sequelae of adverse events. So medications, of course, as you know, for pre-screening, for example, for pre-biologics, really important to pre-screen that. Their hepatitis serology, TB skin test, chest x-ray, vaccination status, and then blood work monitoring for certain medications. I should add on here too, but preventive care also includes making sure that if they have a family doctor, if not, then it's on our end to make sure they are updated on their routine vaccinations and cancer screening as well. Cancer screening, particularly for GI, of course, is colon cancer, but obviously there's all the other population general cancer screening that should be monitored as well. And then for worsening of strictures and fistulas, if we monitor that, we can hopefully prevent complications by picking them up early and getting them treatment or surgery early. And again, a patient is not going to participate unless they understand that we are trying to help them reach their goals. So important thing that I try to teach our trainees is always ask the patient, like, what are their goals for their treatment? And this can vary depending on their age, their sex and gender, where they are in their family planning, if they even are planning to have children, ethnicity, religious beliefs, comorbidities, BMI, all play a role. And then, of course, goals, our goals and their goals might be slightly different depending on their phenotypes as well and how long they've had IBD for. And then there's a lot of other things that we may have to take into account. For example, if somebody is a heavy alcohol use and has cirrhosis, we have to be cautious about some of our medications as well. If somebody cannot afford certain medications, it doesn't matter if we prescribe it to them, they're not going to fill it or take it. So all of those things play a huge role in the collaborative care. And then finally, of course, the patient participation. As mentioned, make sure they understand their diagnosis so that they can explain as well to the people who are helping them, which usually includes friends and family. Investigations, that it's their responsibility to attend the labs. We can order it, we can explain it to them, but ultimately they need to take ownership. And then have that shared decision-making model. And it's just a brief word on the care pathways. So part of this, I would say, like I learned actually from Edmonton, we developed a lot of different care pathways, but this has actually been published several times in many different institutions. So I'm sure you all probably have some kind of care pathways that you follow, whether formally or informally. This is just a typical one, probably for like limited proctitis, to educate the patient about using the topical therapies and then working their way up. And then the cycle of treatment as we assess that they're responding and then going on to maintenance. If they have extensive colitis, it's slightly different and includes the oral therapies. And then again, counseling the patient on monitoring with fecal calprotectin, colonoscopies, and then going on to the appropriate maintenance therapy. So back in Edmonton, I made myself this ulcerative colitis action plan, which I actually took a model from asthma, which has like the red, yellow, green light system. And I didn't actually know back then that there were formal plans that other people were making. So I just put this together for my patients to try to like help guide them to do some self-management until they can get in to see me. Basically, it's, if they're in the green, which means they're like, basically their P-Mayo score is 0 to 1. They would stay on their maintenance meds. If they started having symptoms that were suggestive of a flare, to start taking, topical enemas or topical 5-SA therapies. I often would give them as well the ones that I think understood like their disease and the tests. We would give them the requisitions to do already for stool tests and blood tests, and then advise them to tell us like that they're going to do those tests and they think they're flaring so that we could follow up with them. And then, of course, the red flags, always have to tell the patient the alarm symptoms, which they should go seek medical attention for right away. So then, turns out, as I mentioned, everybody else is doing some sort of action plan. So the Gastrointestinal Society actually reached out, and just recently, Dr. James Gray and Dr. Mindy Lam, and myself kind of tried to help the Bad Gut Society or Gastrointestinal Society make their version of the action plan. It's very similar, green, yellow, red light system, and more spaces for clinicians to now guide the patient and explain to them their fecal calprotectin, actually write out the rescue medications for them, personalize it to the patient and the clinical team. We also developed one for Crohn's now because we realized that a lot of Crohn's can self-manage to some extent. So for the Crohn's one, we added specific things for stricturing disease, to guide the patients about adjusting their diet, and if they have perianal disease, what to do and when to come and seek medical attention. And again, this all needs to be personalized because some patients who are newer in diagnosis may need more guidance versus you have someone who had Crohn's, for example, for 20 years, like they already know some of this. So I find it's very personalized to the patient. And these do work. So there are formal studies, once again, that actually show that this does benefit the patient and reduce overall system costs. This is a study from Royal Alexandra and Vale of Leven hospitals, and they had the ulcerative colitis action plans. This is just their actual handout that they tried to give, explain to the patient about the different medications, differences between the oral and the topical medications. And they implemented this over the year of 2015 to 2016. And you can see in this table, they showed a huge reduction in the number of IBD return clinic appointments for flares from 64 in a year to 8 in a year. A huge reduction in their phone calls from patients calling and asking like what to do next, from 51 to 13. And their IBD related admission went from 4 to 0, and emergency room attendance went from 5 to 0. And then their costs in their currency went from 21,739 to 1,304. So these kind of self-management plans can make a difference in our patients and in the overall health system. This is a formal iStart, eye support therapy access to rapid treatment consensus. Silvio Dines was one of the lead physicians on that one. And again, this is for ulcerative colitis. And basically, again, the concept is a patient-centered collaborative care approach to educate and empower the patient to be able to self-assess and understand their disease and self-initiate to a certain level the treatment strategies. And what they propose is that this can increase the speed of treatment of the flares, rapid initiation of optimization of that first-line therapy, and then there's certain comfort level for certain clinicians and patients to start some addition, for example, topical steroids or oral steroids like the oral budesonide. So again, it needs to be personalized and maybe different depending on different clinician groups. Other things that can be done as well, in addition to these self-management plans, are actual monitoring with e-health and computer systems, implementing those patient symptom scores. So doing that kind of cycle. And I'll briefly talk about that because we are in a COVID for the last 2 years where we had to do a lot of e-health and virtual care. So many provinces and territories have some kind of telemedicine, either phone visits or video visits now are supported by the public systems. Many patients may already be using apps of some sort, like Health Promise or other, like CCC has an app now that patients can monitor some of their symptoms and get some education. And of course, patient social media. The problem is, although this is can empower the patients and help monitoring in between clinics, there's still very limited data long-term. And there may be some overinterpretation from some patients. And there's some thought that, and it has been observed that patients who might be anxious or depression, it might worsen those. So it has to be, again, personalized and tailored to the patient. However, there is, again, evidence that this can reduce things like ER visits or hospitalizations. This is out of McMaster, and they used the Health Promise app. And they showed after a year of using this Health Promise app of monitoring these patients' clinical scores and quality of life scores, they actually showed a huge reduction in the number of emergency room visits and hospitalizations in that cohort of patients. So I just briefly, there's a lot of other publications and studies out there, but summarizing all that, last year there was a systematic review and meta-analysis approach to look at all these. And they looked at all the evidence that was published on remote monitoring with actual computer systems and algorithms, web-based portals, telemedicine, nurse-led monitoring, mobile apps compared to traditional clinical encounters. And they showed that there was a huge decrease in the overall healthcare utilization, mainly outpatient visits, but also reduction in ER and hospitalizations, and then associated reduction in healthcare costs, and no significant impact, so no adverse impact on IBD disease activity, quality of life, or treatment adherence. So when you see that no significant impact, you might think, oh, well, it doesn't really benefit these people. My interpretation is it didn't harm these people. So it provides that extra layer of monitoring and contact to the patients, and without, and it cuts down the outpatient visits and ER visits, hospitalizations, but it did not adversely impact things. So still, that's a positive. And for many patients, it can provide that extra layer of support. The other thing we do in Ontario, we used Ontario telemedicine, and I found that it's very collaborative because many of these video calls would include like these other people. So I do a lot of transitions, so I get a lot of sick kids referrals. And the other day I had the patient was at Guelph because she's attending university, and the parents were in Toronto. And so they all wanted to be on the call together, and we just like linked them all up. We also have in Ontario, the PACE telemedicine program, which my understanding CCC is you're starting to try to expand that to provide, so each hub across, there'll be 5 hubs across Canada, and hopefully they'll be able to support all patients across Canada, regardless of where they live, through these kinds of telemedicine and remote access. So I can see perhaps in a year or two that perhaps it would be the patient, maybe their family member who's supporting them, could be the local gastroenterologist or the internist who's managing their care, IBD nurse specialists, and then the IBD specialist from one of those hubs, and then potentially other people who are involved in their care, and have a full video conference so everybody can collaborate. And along those lines, there have been other proposed collaborative care models. This is out of the Pittsburgh University Medical Center from Dr. Reguero's group. And there's several different pictograms about this, but basically it's the IBD home to try to give each patient a consistency and collaborative team to help them, and it's their home. So the physician, the nurse specialists, dietitians, psychologists, social workers, pharmacists, surgeons, and their other specialists, depending on what their disease is manifesting as. And the concept is to try to give these people a comfort space that they can easily access all the different multiple disciplines that they need access to, but rapid access, and always like the team, so IBD specialists on call to cover them for 365 days a year, and a seamless transition should they require hospitalization from inpatient to outpatient, and then if they need hospitalization again, so that there's no gap or loss to follow-up during that transition. The interesting thing is now, unfortunately, we're having a shortage of family primary care providers, but the concept is to extend the IBD home to the patient's local primary care provider. Ideally, if they had a like family physician or nurse practitioner who's helping them with their overall health, they would be included in this IBD home, because they do a lot of the maintenance monitoring and a lot of the vaccinations, for example, and health maintenance. So that's the most recent idea, is to expand from GI to include everybody else that's involved in the patient's care. So I try to incorporate this in our preconception pregnancy clinic here that I tried to set up here at Mount Sinai. And I learned this in Edmonton again, where I set up the first Edmonton clinic, and then I tried to emulate that same model here, is to try, as soon as I get the referral from these people for these patients preconception, is to find out who is involved in their care, who is, do they have a nurse practitioner? Do they have a family doctor, internist? Do they have a surgeon? Who's their GI doctor? Who's their pharmacist? Do they have an obstetrician? And then I try to get everybody connected. I haven't gotten to the sense where we have, virtual clinics together or anything, but it has gotten a little bit better in terms of communications by either email or we have the Ontario telemedicine e-consult service to try to connect all these people together to make sure that everybody's on the same page when it comes to this patient's care. And to that extent, this is the end of my last slide. Just wanted to invite everybody to participate in my next multidisciplinary care for IBD. And this is an initiative I started a few years ago, including the multiple disciplines, particularly focusing in obstetrical care, but also including nurses and nurse practitioners, dietitians, social workers, psychologists, surgeons, pharmacists, dietitians, I said. And now we're also involving rheumatologists as well to give the next presentation talking about the overlap of rheumatological issues in IBD. And so it'd be really good to have people attending and sharing their experiences on that as well. So hopefully in the last 40 minutes, I tried to quickly cover collaborative care for IBD, strongly multidisciplinary, patient at the center, P4 medicine for IBD, so predictive, preventive, personalized, and participatory, a little bit about proactive action plans. But I'd really be interested to hear from you, what kind of model do you use in your clinics and your clinical practice? Do you use action plans, or do you have these kind of e-health monitoring? Your multidisciplinary team meetings, how frequent are they? Who is involved in those? We're really interested to hear about that. I'm going to stop sharing.
Dr. Huang, thank you so much. That was wonderful. I have a quick question for you. So the digital monitoring slide that you presented, where you said there was no adverse effects on the patients, but there was no positive effects on quality of life either. Is that what you were saying?
That was on the systematic review.
Yeah.
So if you actually read like the individual studies, many studies do show improvement in quality of life, and some studies actually show reduction in like anxiety and depression. But when they looked at all the literature, like in the systematic review, statistical, like meta-analysis things, they show that there was no overall like benefit or harm. So when if you look back at that SWOT, the strengths, weaknesses, opportunities, and threats, one of the threats is that for some patients, these kind of monitoring may be too much for them. Like if they already have anxiety or depression, and then now they're tracking all their symptoms, it could actually make them worse.
Yes, and some patients will use denial sometimes to cope, and that's not a bad thing. And we keep pushing information at them. Sometimes I think we actually elicit more anxiety than we prevent, but there's the balance, and you have to know the patient, right?
Yeah.
And there's a question here from Karen Frost. Hello, Karen, how are you? And she says that we find when families know that the multidisciplinary team is accessible, they tend to dismiss the self-monitoring tools. How do we engage patients to commit to using the self-monitoring tools like Bad Gut tools and the Health Promise apps?
Yeah, I think it's part of it is also, are we looking at the responses, right? So if the patient's filling out all these things on their apps, but there's no connection back to the clinician, then they're not going to do it because they don't feel like that we are assessing that. So the issue with like Health Promise and Bad Gut, I think, has been that it doesn't integrate easily to our EMRs or flags us. So if there's a way, I find that patients will do monitoring or tests if they get that immediate feedback from the clinician. Meaning, like, if they're going to do the fecal cal, if they're going to submit those clinical scores, and they can see the results themselves on the app or like on their, sometimes the fecal home fecal cal tests, they can see the results. If the clinical team does not get back to them, then it doesn't work, right? Like, it's got to be that constant feedback loop. So if a patient fills it out and they flag a PMAO of high score of 4 or 5, and they get a call back from the clinician's team saying, oh, we got your submitted scores back. How are you doing? Like, it says that you're having diarrhea, or like your stool sample test is showing inflammation. I think that's when they'll engage. That's what I've seen anyway in my transition patients. And
like a positive feedback loop.
Yeah, right? I found and I actually learned that from the patient, that they'll call or the email, say, hey, I did the stool test like 3 weeks ago. What's my result and whatnot? And many of them need that, and they want that to know, like, well, they're not just doing the test because of protocol. Someone's actually going to look at it and check up on them, adjust therapy as needed, and then so they'll do another test, and that's part of the plan. I think that's what it is, like a lot of engagement with the patient and having them understand what's the next step, like if they do this test.
Are there any other questions from the group? I'm more than willing to forward the questions.
I'm curious though, like maybe, I don't know if they can type the answers, but across the country and the people who are attending, like how many people do have access to like e-health monitoring in their centers, or their EMR has a way to push out like those partial meal scores or whatever PROs they're using?
I don't think, certainly not in our center, does our EMR enable us to push out that stuff very easily. It's not, things are just not there yet.
It's not there yet. Yeah, I was amazed when I saw all this coming out of the States. Like, I have no idea how they do this, but because every center luckily has a different EMR. But we've been using something called Ocean. Ocean MD is actually a CMA approved platform, and it actually syncs with our, we use Akaru.
Yeah.
And it actually syncs to it. So you can send out these, like, you can design your own survey. So we do, like, I use the actual P-mail score and the HPI and send it out to people before clinic. And then in my pregnancy cohort, we send it out like each trimester, just routinely to get them assessed, like how they're doing in between clinics.
And they're completing them. They're getting, you've got a high rate of.
Yeah, most of them are, like, because they know, like, I think they, like, I say it, like when I call them up for the visits, I say, oh, like your score or your survey, you mentioned this, like, can I ask you more about that?
Yeah. We're still in a stage where we're, some of us are mailing out, things like that prior to visits.
Right.
We're not
Yeah.
really able to generate it electronically. The other thing I was when you were discussing the collaborative clinics in Halifax, we don't have per se a monthly collaborative clinic, but what we do have is what we call complex case rounds.
Okay.
Which is very, you've got the same group of people in the room, right? So you've got surgeons and nurse practitioners and our nurse navigator and our IBD specialists, and you have any GI who in the area who may have a case that they're struggling with.
Right.
So they will present it, or one of us may have come across a case that we're struggling with, and we will present it. So we have brought that group together for that purpose, but we haven't done it on a regular basis, just for a rounds purpose.
Yeah, it's hard. Like, that's what we struggled with. We wanted to do it weekly, but there's not enough pathologists or radiologists.
Oh no, or we can't seem to pin the surgeons down on a weekly basis. Yeah, it's not easy, but we do have pretty good representation of complex case rounds. Karen, what are you saying there? There are 2 digital companies who are streamlining PSP portals to be integrated to e-charts like Epic, rolling out in the next year or so. And that is all. Karen just made that more like a comment than anything else. And I think you're right. I mean, there are certainly things coming that hopefully will make these processes easier for us, but certainly not everywhere in the country are they there yet. They certainly are not.
And that's a challenge too, because some patients, they don't have like easy access to internet or like smartphones.
No,
they might still rely on.
And our older patients, obviously, it's a challenge, a different challenge altogether, right? So our older patients just struggle a lot more, and sometimes I even struggle a lot more than my younger patients do with. It's nothing.
Technology.
It's absolutely nothing. But anyway, that's where we are. Any other questions, guys? What about you, Vivian? Anything else you'd like to?
No, I think this is a good discussion.
It was a good discussion. Very well.
Yeah.
Listen, thank you so much. And I'd like to also thank Faring for sponsoring this talk, and CCC for putting it forward, and certainly for all the participants across the country who sat and watched. Thank you so much, Vivian, and we'll see you again.
Thank you. Nice seeing you.
Bye now.
Bye. Have a good night.